Welcome to AmeenAcademy.com. In abnormal psychology, let us discuss about sexual dysfunction, female orgasmic disorder, and premature ejaculation for case studies. Mrs. X was concerned about a number of problems when she arrived for her first appointment at the mental health center. Her principal complaint was an inability to achieve orgasm during sexual intercourse with her husband, ex-wife. They were both 33-year-old and had been married for 15 years. Mr. Y was a police detective and Mr. Mrs. X had recently resumed her college education. Their children, a daughter and a son, were 15 and 12 years respectively. Mrs. X's orgasmic problem was situated in nature. She had experienced orgasms through masturbation and she masturbated an average of once or twice a week. However, she had never reached orgasm during sexual activities with Mr. Y. The problem did not involve sexual desire or arousal. She found Mr. Y sexually attractive, wanted to enjoy a more satisfying sexual relationship with him, and did become aroused during their sexual encounters. They had intercourse 2 or 3 times each month, usually late at night after the children had gone to sleep, and always at Mr. Y's initiative. Their foreplay was primarily limited to genital manipulation and seldom lasted more than 5 minutes. Frank, Mr. Y always reached orgasm within a minute or two after penetration and often fell asleep shortly thereafter, leaving Mrs. X in a frustrating state of unfulfilled sexual arousal. On many occasions, she resolved this dilemma by slipping quickly out of the bedroom to the TV room, where she would secretly masturbate to orgasm. Mr. Y realized that Mrs. X did not experience orgasm during intercourse but chose not to discuss the problem. He did not know that she masturbated. This situation was distressing to Mrs. X. She felt considerably guilt over her frequent masturbation, particularly after sexual intercourse, because she believed that masturbation was a deviant practice. She was also concerned about the sexual fantasies she had during masturbation. She often imagined herself in a luxurious hotel room having sexual intercourse with a sequence of 8 or 10 men. Her anxiety regarding sexual interest and arousal was also a problem during intercourse with Mr. Y. He had, in fact, made numerous efforts to find out what she found arousing, but she remained uncommunicative. She was afraid to tell him what she liked because she thought that he would then realize that she was oversexed. In addition to Mrs. X's inability to reach orgasm during intercourse, she and her wife, husband, were not getting along as well as they had in the past. Several factors were contributing to the increased strain in their relationship. Mrs. X's parents were both in their middle 40s when she was born. They had one other child, a boy who was 5 years older than Mrs. X. Her father was a police officer and her mother was a homemaker. This is a short history for Mrs. X. In approaching the sexual problem described by Mrs. X, the therapist focused on Mrs. X and Mr. Y as a couple, not Mrs. X as an individual. She was principally concerned with the things Mrs. X and Mr. Y did and said then they were together. It was clear from her descriptions of the problem that she knew very little about sexual behavior. Her reports also indicate that she and her husband were not communicating effectively during sexual activity and were not engaging in effective sexual behaviors. To focus on the relationship, the therapist asked Mrs. X to bring her husband with her to the second treatment session. Mr. Y was initially reluctant to join Mrs. X in treatment because he had always believed that the problem was primarily hers. Nevertheless, he agreed to talk to the therapist at least once, and during this interview, he indicated that he was also dissatisfied with their sexual relationship. On further questioning, he even admitted that he had secretly worried that he was to blame for her wife's orgasmic difficulty. This thought had caused him considerably anxiety from time to time, particularly when he was also worried about his performance in other roles such as work and his relationship with the children. Now, let us discuss further detail about this female orgasmic disorder and premature ejaculation. Case studies show female orgasmic disorder FOD is associated with issues like decreased sexual desire, dyspareunia, that is pain during sex, and psychological factors such as dysthymia, while premature ejaculations PE can cause significant distress, anxiety, dispersion, and marital discord in both partners. Treatment approaches for FOD may include psychosexual counseling and medications like bupropion or centralin, whereas PE treatment involves strategies like behavioral therapy, medications, and addressing potential underlying factors like prostatitis or varicocele. The partner's sexual dysfunctions, specifically PE, can also negatively impact the female partner's satisfaction and lead to distress. Female orgasmic disorder (FOD) case studies. Patient profile. A case series found that women with female sexual dysfunctions (FSD) often experienced decreased desire and dyspareunia. Associated factors. Psychological factors. Dysthymia, a form of depression, was present in some patients, leading to treatment with psychotropic medications. Relationship context. A fear of painful penetrations was noted in one case, and another patient had a complete aversion to sex. Educational background. Many women in the study were highly educated graduates, suggesting that FSD is not limited to less educated populations. Treatment approaches. Counseling. Psychosexual counseling was offered to couples, recognizing the importance of a dual partner approach. Lubricants. The use of lubricants before intercourse was suggested to help with issues like dyspareunia, that is pain in sex. Medications. In specific cases, medications like bupropion for decreased desire and sertraline for dysthymia were prescribed. Premature ejaculation PE case studies. Diagnostic criteria. PE is defined by ejaculation occurring within approximately 1 minute of penetration, relate nearly every time, causing distress. Psychological impact. Chronically experiencing PE can lead to significant anxiety, depression, and stress affecting both the individual and the relationship. Impact on partner. Female partners of men with PE often report reduced satisfaction, increased distress, and relationship difficulties. Treatment modalities. Medications. Depoxetine is a medication that can be combined with behavioral treatment for improved efficacy. Behavioral therapy. Combining sexual behavioral treatment with medications has shown to be effective. Addressing underlying conditions. Prostatitis. Prostatic infections have been associated with PE, and treating prostatitis can improve ejaculatory control. Varicose. An association between varicoceles, enlarged vein in the scrotum, and PE has been noted, with theories suggesting potential effects on intrapelvic congestion and prostatic inflammation. Neurological and metabolic factors. Neurological conditions, metabolic syndrome, and chronic inflammation are being investigated for their potential links to PE. The interconnectedness of FOD and PE. Partner dysfunctions. A significant correlation exists between FSD and MSD, male sexual dysfunction, particularly with an increased risk of PE, is men partnered with women experiencing FSD. Focus on performance. The male partners focus on intercourse duration and performance due to PE can lead to the female partner's distress and lack of consideration for her sexual needs. Interruptions of pleasure. Rapid ejaculation can interrupt the female partner's experience and sexual pleasure, preventing her from reaching orgasm. So far, we discussed about sexual dysfunction, female orgasmic disorder, and premature ejaculations with case studies. We have done. Please subscribe our YouTube channel.